welcome and thank you for coming to the webinar series from the Eye and Ear Foundation called Sight and Sound Bites. This is a bi-weekly webinar series that highlights research at the University of Pittsburgh School of Medicine. I'm Craig Smith. I'm a development officer here at the foundation. The Eye and Ear Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds that we provide from the Eye and Ear Foundation to support research are only made possible because of philanthropic support, and we'd like to thank everybody who has supported us in the past. A couple housekeeping things to talk about today. So this is a webinar series, so the chat is actually disabled. You won't be able to chat. However, we do have a Q&A function open that you can submit questions for Dr. Soose and Dr. Whelan throughout the program, and then we'll hold the last 15 minutes or so to answer those questions. We do ask that you refrain from asking really personal health questions that wouldn't be relevant to the larger audience. However, if you do have questions like that you'd like us to talk to Dr. Soose and Dr. Whelan about, please feel free to email them to me. My email address is craig@eyeandear.org, all spelled out. And please also feel free to use the subtitles function for closed captioning for today's program. You can see that at the bottom of your screen that you can turn those on. And we will also be adding everybody to our email list so that you'll get invitations for future webinars, blog posts, newsletters, etc. So you can keep up to date on all the research and exciting things happening here in the departments and with the Eye and Ear Foundation. Today's topic is Down syndrome and sleep apnea, a new treatment on the horizon. We're joined by Dr. Ryan Soose and Dr. Rachel Whelan. Dr. Soose is the director of the UPMC Division of Sleep Medicine and Upper Airway Surgery and an assistant professor in the Department of Otolaryngology at the University of Pittsburgh School of Medicine. Board certified in both otolaryngology and sleep medicine, Dr. Soose specializes in the medical and surgical treatment of snoring and obstructive sleep apnea. He's an appointed member of the Sleep Disorders Committee of the American Academy of Otolaryngology Head and Neck Surgery and is an active member of the American Academy of Sleep Medicine and the International Surgical Sleep Society. Dr. Soose has a special interest in sedated endoscopy and neurostimulation therapy in the management of patients with sleep apnea. Dr. Whelan is an assistant professor of otolaryngology at UPMC Children's Hospital of Pittsburgh and UPMC Mercy, specializing in sleep medicine. She received her medical degree from the University of Pittsburgh School of Medicine and completed her pediatric otolaryngology fellowship at UPMC Children's Hospital in Pittsburgh. Dr. Whelan also completed an otolaryngology sleep medicine fellowship at Children's Hospital of Pennsylvania in Philadelphia, PA. Dr. Soose is going to kick us off today, so I'd like to turn it over to him now. Dr. Soose.
All right. Thank you, Craig. Thanks to Lonnie and the Eye and Ear Foundation and staff. I appreciate the opportunity to speak with you today. Again, I'm Ryan Soose and have worked and led our sleep division at the University of Pittsburgh Otolaryngology department for about the last 15 years or so. And I really want to introduce Dr. Whelan to you all. You may remember we did one of these Sight and Sound Bites a few years ago on sleep and dizziness. And sleep just impacts so many aspects of all of our lives. This one specifically has to do with Down syndrome and breathing. But I hope this is of interest to you and really want to highlight some of the great work that Dr. Whelan and the rest of our department are doing. So first of all, thank you, Dr. Whelan, for joining us when you're away on your vacation. Appreciate that. Dr. Whelan has been with our department here since 2021. And as Craig mentioned, she really has a unique training that I want to highlight here. This is really unique, and perhaps just a handful of people in the whole country and the whole world have this kind of training. So as Craig said, Dr. Whelan, in addition to her medical school and otolaryngology residency training here at UPMC and the University of Pittsburgh, did 2 fellowships. So one in pediatric otolaryngology to specialize in advanced care of children, but also in sleep medicine at the University of Pennsylvania and CHOP in Philadelphia. So Dr. Whelan splits her time between Children's and Mercy, both adult and pediatric care, ENT, and sleep. And she really brings now huge value to our patients and to our academic mission in the department. She has almost 20 publications already and is doing some important research, one with postoperative opioid use in kids that have their tonsils and adenoids removed, a really critical topic. And what relates to today is she's leading our clinical trial site at Children's Hospital of Pittsburgh, looking at some new treatment for sleep apnea in the population with Down syndrome. So my disclosures first, I have some consulting work with some sleep apnea related companies seen there, and our department has received research support over the years from Inspire Medical, primarily as it relates to being one of the sites in the original phase 3 trial, as well as one of the sites in the global registry. And my other disclosure is I'm a Yinzer and from Pittsburgh, so I have a little bit of a bias in promoting what we do beyond the usual. So a little bit on the big picture here. This is such a huge topic. It's hard to overstate it. Sleep apnea in this Lancet article was estimated to impact about 1 billion adults worldwide. And that's not even counting kids. That's not even counting primary snoring. That's not even counting the elderly. In the US alone, if you look at the middle-aged adult population of about 160 million, about a third of those are estimated to have at least mild sleep apnea where their sleep can be disrupted. And about 1 out of 7 have moderate to severe, where it not only impacts their sleep, but also potentially their blood pressure, their heart, their brain, and other health aspects. In that heat map shown there, that's the country's prevalence of moderate to severe disease. The countries in orange, roughly 10 to 20% of the population have moderate to severe sleep apnea, and the ones in red are up around a third of the population. So unless you live in Greenland, I think there's a lot of opportunity to really help people. And yes, even Sleepy Joe is affected. So this hit the headlines, and there was even an Inspire segment run on Inside Edition last week. And this has really driven up our phone calls and interest here. So it's a very common thing all the way up to our president, and we have an expanding toolbox of medical and surgical treatments that at the University of Pittsburgh, we're constantly trying to refine and improve. We have medical devices like CPAP machines, custom dental mouthpieces, weight loss programs, positional treatments. And then we're also able to implement surgical treatments of the nose, the throat, and the jaw structure. And what Dr. Whelan and I try to do now with each individual is personalize a combination treatment plan that matches each individual's needs and wants and anatomy. Beyond those traditional treatments, there are new ones on the horizon. For instance, we're working on a way to shrink the fat pads in the tongue and in the neck non-surgically. There are some medications for sleep apnea that are in phase 3 clinical trials right now. And we're actually looking to partner with the Eye and Ear Foundation right now and our swallowing center, looking at exercises of the throat to help improve sleep apnea and snoring. But one such newer treatment that's got a lot of publicity, and it's hard to turn on the TV nowadays without seeing a commercial, is one that we helped to pioneer here at the University of Pittsburgh. This is an implantable hypoglossal nerve stimulation system. It consists of a generator, shown with the asterisk there, placed in the skin pocket in the chest, similar to a pacemaker on the other side. And then there are 2 wires or leads. The one shown in white there sits against the rib cage and acts as a breathing sensor. That's what times the pulsations during sleep. And then the other lead shown in black there goes up through the tissue of the neck and ends with an electrode on the nerve that sticks out your tongue, which looks like this. The patient then uses a remote control each night when they go to bed to activate it, to make adjustments, to turn it on and off, to even record data on how it works. This will just give you a little bit of an insight into what some of the surgery involves. We expose the nerve in the neck right underneath the jaw that moves the tongue. But we only want the branches of the nerve that move the tongue forward and open up the airway. So we use our anatomic knowledge as well as this little nerve stimulator probe with electrodes on the tongue to identify the right part of the nerve, place a small electrode around that key part of the nerve, and then when it works appropriately, what we see is a nice stiffening and forward motion of the tongue while people sleep. This is just shown schematically here, where that electrode is placed on the nerves that just stimulate the muscles that move the tongue forward, not the red ones there that pull it back. And similarly, this is what it looks like when we turn it on in the office. Just a nice gentle stiffening and forward motion of the tongue. So it's hard to believe we've been doing this now already almost a decade, and we were the primary site in the 22-site STAR trial, which was the phase 3 pivotal study back in 2010 to 2014, a study across the US and Europe, and published the key 12-month data in the New England Journal. That led to FDA approval, and we did the first implants in the country right here at UPMC Mercy. Over the next several years, there was a lot of clinical trial data that we published from that trial, as well as from other studies and our own experience in Pittsburgh. There's a global registry that we set up at that time to collect data, real-world data on these patients from about 50 different centers around the US and Europe. And the enrollment in that just capped recently at 5,000 patients, which is incredible. The first pediatric implant was done in Boston, which we helped to set up and facilitate at Harvard. You'll see some more of that here shortly. One of our former residents actually modified the technique a couple of years ago and reduced it from a 3-incision surgery down to 2, streamlining it and shortening the anesthesia. And then last year, it became fully MRI compatible. And so currently, just in less than a decade, I think it's pretty incredible. We went from 1 center in Pittsburgh to now 700 centers around the US. About 50,000 patients now have received this therapy. Again, the registry is filled, and we recently expanded the therapy to Asia. We had the surgeons from Tokyo and Singapore fly in and personally trained them in the cadaver lab, and now they're taking it to a whole other part of the world. So how does this dovetail with Down syndrome and the work that Dr. Whelan's doing? Well, sleep apnea is actually incredibly common in Down syndrome. So it's already common around the world, and in patients with Down syndrome, it's incredibly common. And I think Dr. Whelan will touch on some of the reasons why that's the case. In this study out of the University of Texas, 90% of the group with Down syndrome had at least mild sleep apnea. That's in comparison to 2 to 5% of the general pediatric population. And almost half of those had sleep apnea in the severe range. Shown on the right there is Jesse. He's the, at the time, 14-year-old patient with Down syndrome who received the first Inspire implant at Harvard now about 8 years ago. And he had a tracheostomy in his whole life because of the bad sleep apnea. And it was a big touching story on the Boston News, where once the Inspire was working, he was able to swim with his friends now that he was able to have his tracheostomy removed. And so what are some of these challenges? Well, number one, patients with Down syndrome are already often struggling with issues related to cognition, attention, memory, and patients with Down syndrome are at risk for early onset dementia, shown in the MRI there. And we know that untreated sleep apnea worsens those neurocognitive issues. Number two, about 2/3 of patients with Down syndrome have congenital heart disease, like the septal defect shown in the diagram there. And again, untreated sleep apnea puts more strain on the heart and worsens cardiovascular disease. And then in addition to being more at risk, patients with Down syndrome often have even poorer results with the standard treatments. Despite the just cuddly appearance of the giraffe CPAP hose there, believe it or not, the CPAP compliance or acceptance rates are pretty poor in this population. And even the traditional things that we do, like removing tonsils, have pretty mediocre results. It helps, but doesn't fully eliminate the problem. So there's a huge research opportunity, perhaps, to combine something that we've really made into a robust CPAP alternative on the adult end and translate that into this great clinical need on the pediatric and Down syndrome end of things. And there's no one better to bridge that gap here than Dr. Whelan. So I'll turn it over to her to segue into where this is going in the future.
I just wanted to start by thanking Dr. Soose for such a warm introduction. As many of you probably know, Dr. Soose is not only the all-star and the pillar of our sleep surgery program here in Pittsburgh, but he's also internationally known as, one of the worldwide leaders when it comes to Inspire therapy. So I've been so lucky to be able to come back to Pittsburgh and work with Dr. Soose and the Mercy team. And I'm excited to have this opportunity through the foundation to talk today as well. So that was a really wonderful introduction in terms of the burden of sleep apnea, starting to talk about some of the treatment options. What I'll do is kind of hone in, and we'll spend the rest of the hour really focusing on patients specifically with Down syndrome. I think what's exciting and unique is that when we talk about patients with Down syndrome, really, it opens up the doors to really have a discussion about sleep apnea in general, and then specifically patients that perhaps are, have medical complexity or comorbidity. So yes, this is specific to Down syndrome patients, but a lot of these characteristics and kind of how we think about patients are really patients with special needs as well as Down syndrome. So, kind of opens the door to talk about medically complex patients more generally as well. So I think it's helpful to sometimes frame the discussion through visuals. So when we talk about sleep apnea, what we're actually talking about is partial or complete obstruction of the tissues that make up the upper airway. And we think about the upper airway really being the tissue from the nose to the level of the voice box. What you'll see in this video is really a great representation in terms of what actually happens with sleep apnea. What you're looking at now is a camera that's placed through the back of the nose, looking at the back of the nose and the back of the throat. You can see this patient is asleep in the operating room. And what we're seeing is with every breath in, you can really get a sense that there's essentially complete obstruction at different levels along the course of this upper airway. This lumpy, bumpy tissue that you're seeing here is the tissue at the back of the tongue. And you kind of get a sense, if you can see my cursor here, that the tissue down here is where the voice box is. That's really the start of the windpipe. You can imagine, I'll play this one more time so we can really get a sense. You can imagine with this level of obstruction with every breath over the course of the night, it's really impossible to really get a good night's sleep. Patients, when you're having this level of obstruction, and this is really what sleep apnea is, obstruction of that tissue. You can see here, this patient unfortunately has multiple different levels until you get to the vocal cords here, those little white stripes you can see. And when that happens, you not only get a good night's sleep, so your sleep quality and your daytime function is affected, but we also know that bad sleep apnea puts patients at increased risk for things like cardiovascular disease, increased stroke risk. And we're learning more and more that there's definitely a big link between cognitive issues and likely dementia and Alzheimer's concerns as well. Those issues, as Dr. Soose mentioned, are already problems that are magnified in the Down syndrome population. So they're a more vulnerable population at baseline. And when you add untreated sleep apnea to the mix, it really magnifies the scope of the problem for these patients. So we understand that it's a common problem and it's a problem that requires treatment. In an ideal world, when we start talking about treatment options for sleep apnea, it's almost impossible to have this conversation without starting to talk about CPAP or BiPAP machines. And really the way these machines work is they give just pressure to those areas that we watched in that last video to really stent open the airway so that air can be exchanged through that portion of the anatomy. So it's not oxygen, it's nothing like that. It's really just air pressure to stent open that airway. And in an ideal world, everybody that we put these machines on will look like this cute baby in this picture on the left. Unfortunately, I think a lot of times what happens is you more so get, the image on the right. And we see patients really that range from the pediatric side to the adult side that have at least attempted to use a CPAP machine for sleep apnea. And unfortunately, sometimes we just can't get it to be a good fit. It's the gold standard for treatment because it's the only thing that's really going to prop open the airway and stent open the airway. So when we can make this work for patients, far and away, that's going to be the best treatment option. However, for the 50+% of patients with Down syndrome specifically that just can't tolerate the therapy, then we need to talk about, well, what are the other options that might make sense? So when we start to talk about alternatives to CPAP, we really start to talk about largely surgical treatment options. And so from a surgical standpoint, particularly in the pediatric side, but many times also on the adult side, we think about kind of tonsils and adenoids, this enlarged lymphoid tissue that lives in the back of the throat, the back of the nose, as being kind of the first gatekeeper from a surgical standpoint. You can imagine that if you look in the back of somebody's airway and you see tonsil tissue that looks like in this picture where it's really occluding the entirety or the majority of the back of the throat, it's not a far cry to imagine that when a patient like this goes to sleep at night, that they're really going to have a problem with that tissue blocking the back of the throat. So usually if there's enlarged tonsil and adenoid tissue, we generally address that as the first surgical step. However, there's a pretty high rate of patients that still have persistent sleep apnea even after that tissue is addressed. And so in patients with Down syndrome, as Dr. Soose mentioned, even once this tissue is removed, 50, 70, some studies even cite up to 80% of patients still have some degree of significant sleep apnea once they recover from tonsil surgery. And so the next thing that we think about from a surgical standpoint is actually another set of tonsils that we have located at the very back of the tongue called the lingual tonsils. And you can imagine if the tissue at the back of the tongue is hypertrophied and large, then it really pulls the weight of the tongue back and contributes to sleep apnea. So many times the next kind of surgical step in patients with Down syndrome will be a lingual tonsillectomy to shave down that tissue as well. And then after that, for going down our algorithm here, we tend to think about additional soft tissue or skeletal surgical options. And so sometimes we address turbinates, which are tissue in the front of the nose, particularly if patients have a very allergic or chronic nasal congestion component. There's data suggesting that shrinking down these turbinates that live in the front of the nose can be beneficial from a sleep, quality of daytime function, quality of sleep, and breathing standpoint. Sometimes, particularly in the pediatric population, we'll address this tissue that sits above the level of the voice box, which are these little, you can see the white vocal cords down here. This is a pretty dramatic example here of the impact that skeletal surgery, actually advancing the upper and the lower jaws forward, can have. You can imagine that with such, a recessed jaw, the tongue, the soft tissues, the muscles of the throat are going to really have a propensity to fall back and contribute to sleep apnea. By expanding the upper and the lower jaws, creating more space and pulling all of those structures forward, you can really, really impact sleep apnea. And then a somewhat non-surgical option that, in my opinion, I think we're really underutilizing a lot of the times, palatal expansion, or sometimes called rapid maxillary expansion. The thought being basically that if you create more space in the roof of the mouth, that the tongue now has somewhere to sit. So likely there's going to be less of a propensity for the tongue to fall back and block the airway by expanding that palate, and also making more space basically for the floor of the nose and improving nasal breathing as well. And sometimes we've kind of exhausted all of these potential surgical targets. And obviously this is really, really dependent on every individual patient's anatomy. And sometimes once we've gone down this whole algorithm, 10 years ago, we really kind of threw our hands up and said, well, could we try CPAP again? Is there anything else we can offer? And for Down syndrome patients, there was really nothing on the horizon until this idea of Inspire therapy really hit the scene. And Dr. Soose, we're so lucky to have him in Pittsburgh. He was really the pioneer for this research back about 10 years ago. And seeing his tremendous results in the overarching adult population made people start wondering, well, how translatable is this to the Down syndrome side of the world? Currently, when we think about Inspire therapy in Down syndrome patients, we're currently implanting this for patients 13 years and older with a diagnosis of moderate or severe sleep apnea who are unable to tolerate or to benefit from CPAP or BiPAP therapy. There are still some weight restrictions. On the adult side, a BMI of 35, although we just are receiving approval to increase this BMI rate in the overall adult side to a BMI of less than 40. In children's, we're using a cutoff of the 95th percentile from a BMI standpoint. So it's not for very, very obese patients, with the thought being that if there's too much weight really in the tissues of the upper airway, then that stimulation where the therapy works through is not going to be able to overcome the weight of those tissues. And the last thing we want to do, obviously, is put any patient through a surgery unless we really are convinced it's going to be an effective treatment option. And then the other big thing is we need the appropriate pattern of collapse. And when I say that, really, we just need to make sure, like those videos that we watched at the beginning of the talk, that it's really the back of the tongue, that the anatomy is moving forward to back, and that pulling everything forward is really going to be an effective way to treat sleep apnea. Sometimes, like this picture on the right, if it's the sides of the throat falling in, you see you kind of get this little pinpoint effect. If it's really that pattern of collapse, then perhaps Inspire, again, is not a great treatment option. So when we started implanting adults with Inspire therapy, we looked at a subset of adult patients with Down syndrome. And when you look in the literature, there have been several different studies done looking at adults who have had adults with Down syndrome who had Inspire implantation. And, you know, in an otherwise healthy adult population, you're able to get a direct sense from your patients. Are you feeling better? They can pretty easily tolerate coming into a sleep lab and getting a formal sleep study once they're healed after surgery to really get an objective and a subjective sense. You can imagine sometimes, depending on functional limitations, it's harder to really use those same clinical endpoints in your patients with Down syndrome or otherwise patients with special needs. And so when we look at studies, really we look at parents and caregivers saying, how much better does it seem like the sleep is? Really, what's daytime function like? Do patients seem to have more energy? Are they more engaged? Are they nodding off? Are they nodding off less? Are there less behavioral issues or concerns during the day? And also, most of the time, we can at least get some level of sleep study data to objectively say how much better is the sleep. And when you look at this kind of special subset of adults with Down syndrome who have been implanted, overall, it seems like even though we can't get as robust information on the adult side, it seems like overall sleep is a lot better. And so again, we tend to think about Inspire therapy on the adult side for Down syndrome patients. Once we've kind of exhausted all other, you know, less invasive options, potentially being a very effective treatment option. And then in more recent years, over the past 5 years, we've really begun to say, well, if this is an effective option for adults with Down syndrome, perhaps this has some utility on the pediatric side as well. And so when you look at kind of the press and the media over the past few years, there have been several good publications espousing the merits of patients with Down syndrome in the pediatric world who have been implanted. When we look specifically at kind of the numbers, the the kind of landmark study on the pediatric Down syndrome side really looked at the first 20 adolescent patients with Down syndrome who were implanted with Inspire therapy. From an objective side of things, their sleep apnea numbers got a lot better. On average, they went from pausing or stopping their breathing 20 to 25 times per hour down somewhere closer to the 3 to 5 times per hour range, basically curing or significantly improving the degree of objective sleep apnea. Talking to parents and caregivers, there were significant improvements really across the board. Sleep seemed better. And most of the time for most families, it's really the daytime function that's the most important measure of all of this. It seemed like school performance, cognition were sharper, better. Interestingly, there were a lot of families in this kind of first arm of these 20 patients that said their speech seemed better. So it's a little bit unclear. Is that because, from a cognitive standpoint, they're clearer during the day? There was some question, is it actually that, we're stimulating their tongue? We know that there's some degree of muscle weakness in patients with Down syndrome at baseline. So is it possible that this is almost like, physical therapy for the tongue and for those muscles? And is that why the speech and articulation improved to some degree? Perhaps it's a combination of those things. Anytime you're implanting a device in children that we know is hopefully going to last the entirety of their life, there's considerations, right? So we know with Inspire therapy, the battery lasts probably 10 to 12 years is a most accurate representation. But it is, at least at this time, a surgical procedure to actually replace the battery pack that lives in the chest. And so, by signing a child up for this surgery, that you're signing them up for subsequent procedures, subsequent anesthetics every decade or so for the rest of their life. There was some question, if you remember, there's that little wire that tunnels between the incision in the neck where that electrode sits to this pulse generator that sits in the chest. There was a question in terms of, sure, you leave slack in the neck, but as the neck grows, as these patients grow, what's going to happen to that wire? It's not been an issue thus far. The thought is that probably if you're implanting an adolescent with sleep apnea, the degree of neck growth that will happen from the time of adolescence on is likely, maybe a couple centimeters over time. We don't think it's going to be an issue, but definitely something to consider. There's also been this question of MRI compatibility. In the most recent iterations of the device, we now have full body approval. So not an active concern, which is a good thing. Interestingly, I did see one patient with Down syndrome who was an avid roller coaster rider. That was like his favorite thing, every roller coaster park in America. And that family had the question, is this going to be, safe from a Tesla and a Revolution standpoint? Is this going to be a potential issue? I don't know. My bigger concern was honestly, the straps on some of those roller coasters kind of sitting down, snugging tight to the chest, right where that device would potentially sit. So sometimes unique considerations in patients with special needs. And then also, of course, when you're talking about any kind of device implantation from the pediatric side. It's been kind of an exciting year for those of us that are pediatric sleep surgeons because of this kind of pilot work that's been done over the past 5 years. Back in March, so just a few months ago, there's officially FDA approval for Inspire implantation in adolescents, so pediatric patients 13 years and above that have Down syndrome. So those were really the studies that led to this approval, which was very exciting. In terms of the research from a Down syndrome and a therapy standpoint, there's really two big studies that are going on currently in the country. In Pittsburgh, we're fortunate enough to be one of those sites actually for both of the big studies that are going on. The first big study is really looking at all patients 13 years and older with Down syndrome who are being implanted with Inspire. And we're really interested in looking at neurocognition in those patients. So they're getting this full battery of executive function and cognitive testing before implantation, and then 6 months, and then yearly after the Inspire device. And we're really trying to assess, families are telling us that cognition is better, but we really want to get an objective sense. Does it seem like by improving the sleep apnea, how much really are we impacting cognition and neurofunction for these patients? So stay tuned. I think we're all really excited to see what the results are going to show. The other big study that is including Down syndrome patients, as well as just all patients, all comers with special needs. We have a long-term registry going on looking at kind of the 5-year outcomes of young adults with sleep apnea who were implanted with Inspire. So this is really trying to look at the 18 to 21-year-old range. This is a study that are encompassing 5 sites across the country. Children's Hospital here in Pittsburgh is one of those sites. And so we're actively recruiting and enrolling for that study as well. So hopefully, in another 5 years, when we give our next segment of this talk, we'll have some great results from this work as well. So I'd love to take any questions. I figured anytime I give a pediatric sleep talk, I can shamelessly put a picture of my own little sleepers. I have 2 boys myself. And so thanks so much for paying attention. Love to take any questions.
Thank you, Dr. Whelan, and Dr. Soose, thank you as well. We do have a lot of questions already, so we're going to kind of dive right in here. First question is there any research going on aiming at the use of rechargeable batteries, which could be accessed and replaced without surgery?
Yeah, I can take that one. When we first were developing Inspire, this was one of the hot topics, and there were several other companies that were developing these, and one of them had and actually continues to have a rechargeable battery, but not so sure if it's a good thing. The Inspire battery currently lasts about 10 to 12 years, which is a good time. In the pediatric population, that becomes more of a thing you have to plan for then, setting up for a brief or outpatient surgery. Many of the patients that receive this on the adult end that are 65, 75, 80 years old, that battery lifespan is actually very effective and even a one-time thing. The rechargeable one requires the patients, at least in its current state, to put a charger over the device for about an hour at a time, and it has to be done about once or twice a week. So with busy lifestyles, it's from the patient feedback we've got, it's actually more cumbersome. And then what that leads to in our experience is forgetting to use it because it's not charged up. But I don't know, Dr. Whelan, do you have any other thoughts? Would you, if you were designing a new one, particularly for the Down syndrome population or other special needs populations, would you make it rechargeable or not?
Yeah, I think technologically, it sounds like we're just not there yet. I think when there's a better capability than having, a charger sit there for an hour several times a week, it's going to be a great option. But I agree, it sounds like we're just not quite there yet.
Yeah, it's a great question from the audience there. And I should point out that there are 4 or 5 other companies now that are trying to do what Inspire did and is doing, but in different ways. And one of those technological changes that is currently in development and in trials is to take the battery completely out of the patient. So the battery would be external. For instance, it could be on the nightstand. There's one in clinical trials now where the battery of the device is taped underneath the chin. It's called Nyxoah, Nyxoah. And that may be FDA approved within the next year. So that's good because there's no battery inside that has to be changed, no wires or anything. You just tape the device under the chin. The downside is, are people going to tape it on there? Is it going to stick? Men with facial hair, it could be an issue. So these are all challenges, but maybe the future is instead of just one device, you have about a half a dozen different ones to pick from, depending on what each person needs.
Okay, thank you. Next question is, can Inspire be used effectively for CSA? I'm hoping that you guys know what CSA is.
Go ahead, Dr. Whelan. Do you want to tackle that one? You probably see some CSA in some of the syndromic kids. I think we were mentioning cerebral palsy at the beginning there, where that could be the case, and even in our adults, say with heart failure and stuff.
So this is obviously a question from somebody that's very well educated about sleep apnea. I want to start just by kind of telling the group there's really two kinds of sleep apnea. And when people think about kind of the, generic form of sleep apnea, when people say, yeah, I know somebody with sleep apnea uses a CPAP machine, he hates it. People are really talking about obstructive sleep apnea, meaning that tissue in the back of the throat falling back and physically blocking the air from getting down. There's actually another type of sleep apnea, and that's really what this central sleep apnea, CSA, is. With central sleep apnea, rather than an actual physical obstruction, it's an issue where the brain is not sending a signal that it's time to take a breath. And so rather than patients trying to get a breath of air and just not able to get it past the back of the throat, there's a pause in breathing. And so you'll hear just kind of, and then patients resume breathing. And we know that the rate of central sleep apnea is higher in patients with any kind of cardiac problem. And so because of the cardiac issues that are associated with Down syndrome, we see a pretty high rate of central sleep apnea. Because Inspire therapy and all these, kind of down the pike forms of neurostimulation are really trying to get that tissue out of the way, push the tongue forward, push it out of the way. It's really not a great option for central sleep apnea. It's actually one of the things we say, if there's a high percentage of central sleep apnea, we don't recommend implanting the Inspire.
Yeah, and I would just echo that too, even from an insurance standpoint and FDA labeling standpoint. If the sleep study shows more than 25%, more than a quarter of the breathing events are the central type coming from the brain rather than the blockage type coming from the throat, Inspire is not even approved. And then the second point I wanted to make is there is even another type of nerve stimulator out there for this CSA or central apnea. It's called the Remedy device, REMEDE. And this is something that's done by cardiac electrophysiologists. And it looks similar to Inspire, but instead of stimulating the tongue, it stimulates the diaphragm to breathe.
Is there an upper age limit for Inspire use?
There's not. On the adult end, what's really interesting is that we actually see a positive correlation with age and outcomes. And that's, maybe one of the few benefits of getting old is that it seems like Inspire actually works better. We don't know why exactly, but some theorize that as we get older, some of what causes the sleep apnea is more of a loss of muscle tone in the jaw and tongue. And this therapy might be uniquely adapted or applicable for that particular problem. So there's not an upper age limit as long as somebody's safe from a medical and anesthesia standpoint to undergo the insertion of it.
Is there any data on using Inspire in adults over 40 years old with Down syndrome?
So there is some data looking at the adult subset of Down syndrome patients that have had Inspire therapy. The results overall are a little bit mixed depending on the study that you look at, but the trend suggests that overall it's a reasonable option to consider for patients that you as the surgeon think are a good candidate. So yes, it's an option for adult patients with Down syndrome. And overall, if you're picking the right patients, it seems like it's usually a good option.
This person, so she's inquiring about her brother who has Down syndrome, and she's asking, has the BMI limit increased because they were told a BMI of 21, and they're wondering if that has increased or if they should see another clinic.
What we see is that overall, when you look at all patients, we tend to see that there's some degree of a correlation between a lower BMI and more effective results with the Inspire. That being said, every patient just anatomically is built a little bit different. From a clinical standpoint, it's really more so about how much, what does the upper airway look like? If you have tissue, large tissue, fatty tissue in the back of the tongue or the sides of the throat, it's a problem, right? If it tends to be, more so belly, hips, and the, structures of the neck and the back of the throat are not affected, so it's, there's some correlation between BMI, but more so it's about the individual patient. I think, probably we used to say a BMI of 31, 32 is more ideal. So that's probably, what you've been told in the past for your brother. But it's reasonable to at least consider, an anatomic evaluation and see. Ryan, I don't know if you have additional thoughts in terms of how you usually counsel about BMI.
Yeah, it's a great, response there. As clinicians, we're a little bit caught in the middle of having to use this BMI metric, which is really a crude number and doesn't really tell you anything about fat distribution and the airway structure and mechanics. So we look at the whole picture, as Dr. Whelan said, but from an insurance auth standpoint, when Inspire was first FDA approved in 2014, the FDA placed a warning or precaution on it for use of a BMI under 32. And then the insurance companies take that precaution and then label it as we don't cover it if your BMI is 32.1. About 4 years ago, it was increased to a BMI of 35. So Medicare and most commercial insurances will cover it up to a BMI of 35. And then just in the last, 2 weeks, Inspire got FDA labeling to improve or increase that precaution up to a BMI of 40. Now, I think that's a little controversial within our specialty. I think that has the potential to really start to diminish results if not done thoughtfully and correctly. But the point is the BMI criteria is expanding. It went from 32 to now 35 and potentially even up to a BMI of 40. But I think when you get in that 35 to 40 range, you really have to be selective.
Cardiac events are prevalent in individuals with Down syndrome. Is this linked to sleep apnea, or is it more of a what came first, the chicken to the egg situation?
So there is a link. Cardiac problems are complex, right? It's a huge umbrella. And we know that there are congenital heart problems that are associated with Down syndrome. And there can be also rhythm problems. We tend to think that sleep apnea, obstructive sleep apnea, can over the long term put more stress on the heart. We see a link with rhythm problems like atrial fibrillation. On the flip side, these congenital heart problems can sometimes increase the risk for that central form of sleep apnea that we've talked about. So it gets kind of, I think, murky and complicated to some degree, but there's absolutely a link between cardiac disease, comorbidities, and sleep apnea, both obstructive and central sleep apnea.
Yeah, I agree with that. It's really a two-way street, right? So there's lots of data that show that untreated severe sleep apnea worsens most cardiac conditions, AFib, high blood pressure, heart disease, heart failure, et cetera. But those cardiac conditions also then worsen the sleep apnea and make it more complicated. So the two feed off of each other, and there's probably multiple mechanisms why. When you obstruct and stop breathing, most patients aren't aware of it because they're sleeping, but that causes this fight or flight response. We call it a sympathetic response. And that fight or flight response releases adrenaline and inflammatory mediators, and your heart rate shoots up, your oxygen drops, and those things night after night after night for many years then probably start to take their toll from a cardiac end.
So this is kind of a related question. Why do people with Down syndrome have a higher incidence of sleep apnea?
So that is very multifactorial, we like to say. So there's lots of reasons to create this kind of perfect storm. From an anatomic standpoint, unfortunately, patients with sleep apnea are just at a really, they're a good setup to have bad sleep apnea. So they tend to have larger, floppier tongues. And so what that means is that there's more of a propensity for the tongue to fall back. When you couple that with the fact that there's a degree of hypotonia, meaning muscular weakness, you can imagine you have a larger tongue and it's more prone to fall back. It really increases the risk for the other tissues and muscles in the back of the throat to fall back. All of those together create the perfect storm to have worsening sleep apnea. So the incidence of overall sleep apnea is higher. And when we look specifically at severe sleep apnea, the risk of having more severe sleep apnea is also higher.
So does sleep apnea in patients with Down syndrome become more prevalent as they get older?
That's a great question. I don't know if we have great data on that. Probably we don't. There are issues in terms of how reliable the sleep testing becomes for a lot of patients with Down syndrome and other special needs. I don't think we have great answers for that.
Yeah, I agree. I don't think there's any longitudinal studies that track the progression of it. In the general population, age itself may not be a strong predictor of the sleep apnea getting worse, except into advanced age. But weight gain certainly is the strongest thing. So I think a lot of what drives the worsening sleep apnea over time is you see poorer sleep, more tiredness, other health and activity changes. That leads to weight gain, which then further worsens the sleep apnea. But to Dr. Whelan's point, one of the big challenges in the Down syndrome population is it's hard to even get the test to show the diagnosis and show the severity. And especially in pediatrics, even to this day, the only type of testing that's approved is one of the in-lab sleep studies where you spend the night. In a general population, people often don't tolerate that well. They're in a foreign bed, it's uncomfortable, they have wires on, they have a video camera, it's not the right temperature, it's noisy, all these other factors. If you take a kid, with Down syndrome, the likelihood of getting any decent data and leaving those wires on is even more exponentially reduced. So I think this is an opportunity, and would mention this to any listeners on that have interest. We're looking to do some of this research here at Children's with Dr. Whelan and at the University of Pittsburgh here to try to see if we can take some of these newer, smaller, minimally invasive sleep testing devices. There are some wearables, many of even your Apple Watch and these different rings and things track sleep data. That might be a great way to answer those questions and track sleep apnea progress and long-term care in these populations.
Can patients with Inspire feel it once it's implanted, and are there any side effects to it?
Ryan's kind of Dr. Soose is the master of this.
Yeah, go ahead. Do you want to? There's lots. I'm sure we both have some answers to these. Go ahead.
Right. Please. You answer and I'll piggyback if I have additional thoughts.
Yeah, there's two parts to this Inspire. There's the implant, the surgical installation of it. And 99% of people get through that without any issues surgically, meaning no major complications or anything. It's a pretty standard outpatient surgery and straightforward recovery. But then there's the therapy use. And so the long-term using the therapy over 10 to 12 years. And the most common side effect that we saw in our clinical trials and still see today is discomfort related to the stimulation. So we're constantly trying to find the sweet spot, if you will. We need to turn it up high enough and strong enough to move the tongue and open up the airway. But in some people, it's a fine line. You go a little bit too strong. Now the therapy itself wakes them up. And so that stimulation-related discomfort or stimulation-related sleep disruption can be a challenge, but we have great clinical staff that we work with every day to customize the settings. So it's not just an on-off switch. There are dozens of different electrical parameters that we can customize to try to minimize that.
So you talked about, how losing weight can help with sleep apnea, but are there any specific exercises or even stretches that can help with sleep apnea?
We're trying to figure that out. Dr. Soose is involved. I think he may have mentioned a study to look at kind of the muscles of swallowing and do strengthening the muscles of the throat. Is there any potential that harnessing those muscles and improving that muscular control, does that help sleep apnea at all? I don't think we have the answers to that quite yet.
Right, but it's promising. We have a fantastic swallowing center, as many of you know, with speech pathologists and voice and swallowing specialists. And many of the throat exercises that those clinicians employ to help with swallowing disorders and even voice disorders may have a positive impact on the muscle tone of the throat as it relates to sleep and breathing. It's the same tube, right? That's your vocal mechanics and your swallowing and your breathing. And so there's probably a good opportunity for cross collaboration. And we have some early trial planning going on right now and over the last few months between our sleep division and our swallowing division to see if we can collaborate and employ a group of swallowing exercises that would not only improve their swallowing dysphagia, but also improve their snoring and sleep. So I think it's interesting, and some of this even came out of the music world, I guess you could say. There was a study or two that showed playing certain instruments, even playing the didgeridoo, improved people's snoring and sleep apnea. And there's been some smaller studies in other countries showing that certain throat and tongue exercises may help with sleep apnea too, but it's all very preliminary. I think the biggest potential is that if simple exercises helped even a little bit, there's like zero risk, right? It's low cost, it's low risk. It would be very applicable to a wide swath of the population. As great as Inspire has been for a number of people, the scalability is still in question because it takes, a lot of resources to get approved and to have that surgery. And so we do need more simple, less invasive things, even if they're only partially effective.
Do you see it being possible for a patient with Down syndrome to bypass CPAP treatment or a tonsillectomy and go straight to the Inspire therapy? Or is it sort of try the first step and go from there?
Like Dr. Soose had just mentioned, Inspire, yes, it's, a relatively straightforward outpatient surgery, but it's still a 4-hour surgery under general anesthesia. So we really like to go stepwise. And so we like to exhaust all the, kind of other options first. Some patients, we occasionally do see patients that they're just, there's no way, no how CPAP is ever going to be an option. And for patients like that, it's at least worthwhile. And Dr. Soose, I'm not sure if you have, additional recommendations that you do in your patient practice. What I tend to do is at least bring people into the sleep lab for a night and say, well, try it for at least a night. We got to at least try something. Because similarly, when we think about the kind of risk benefit to trying CPAP, what's the downside to trying a CPAP? Well, maybe you're right. Maybe your loved one ends up hating it. You're like calling the medical supply company, begging them to come pick it up a week later. But what's the potential upside? Perhaps it's not as bad as you thought. Perhaps you actually really like it, get better sleep than you've had in a long time, do some troubleshooting, but end up finding it to actually be a great option for you. So I think when you talk about kind of the risk benefit ratio to trying CPAP, there are very rare instances that it's not at least worth a shot for most patients.
Yeah, I think that's a great way to approach it. And I'd say in general, Dr. Whelan and I and our whole team, we try to take each person individually, whether it's a kid or an adult, any type of patient across the spectrum, and see what can we do to get better sleep and better health with the least amount of risk, least amount of invasiveness, and kind of walk up the ladder from there as needed.
The other thing I'll say specific to the Down syndrome population is that there's oftentimes a behavioral and a psychologic component that goes into it, right? Even for, patients without special needs, the thought of putting a mask on, there's not that many people that immediately warm up to it. So a lot of times, particularly in the Down syndrome population, it's really important to have some kind of behavioral sleep psychologist that's able to help acclimate patients, really maximize the chance of success when you're going to try a CPAP machine.
You know what, Dr. Whelan, that is a great point. I'm actually so glad you brought that up. And Craig, this is probably a good, topic to step back and even finish up on. Is we're only talking about one of dozens of sleep disorders. And most of these patients don't come in to have their apnea score treated. They come in to feel better. And many people have 3, 4, 5 different sleep disorders. They have some insomnia and some chronic pain and some restless legs. Medications affecting their sleep, stress is affecting their sleep. There's dozens again of different sleep disorders, and I think the value added of having somebody like Dr. Whelan, who's double trained and double boarded in both sleep and ENT, is that you can manage that patient comprehensively rather than just tunnel vision on one aspect of the sleep disorder.
Well, this has been really great. We want to again thank Dr. Soose and Dr. Whelan for joining us today and giving such a great presentation. As always, a recording of this webinar will be available on our website in the coming days. So check back there if you want to watch it again or share it with any family and friends. We look forward to our next webinar. We hope you all join us in 2 weeks, where we'll be having a presentation on hearing with the brain with Dr. Ross Williamson and Dr. Phil Perez. So once again, Dr. Soose, Dr. Whelan, thank you so much for joining us, and we hope everybody has a great day.